So we're in for another treat here. We're going to have our next speaker is a pulmonary critical care specialist at Medstar Washington Hospital Center, where he oversees the management of mechanically ventilated patients and the clinical practice of the pulmonary services department. His adult critical care practice interests include patient ventilator asynchrony, esophageal pressure monitoring, ARDS management, organ donation, and Ecmo. He sits on the interdisciplinary Ecmo, ARDS, and organ donation and critical care practice committees. Please join with me in welcoming Kriner, the speaker today on the fundamentals of mechanical ventilation and its use while on Ecmo. Welcome, Eric.
Thank you. Thank you so much. I am going to bring my screen up and we will get ourselves started here. Here we go. Okay. All right. I super appreciate the opportunity to speak with you guys. It is my first perfusion conference. So pretty excited about that. I speak at probably 20, 25 conferences a year and have yet to hit a perfusion one. So this is pretty great. I am going to be talking about fundamentals of mechanical ventilation separately, and then that mechanical ventilation and its use while on Ecmo. All right, so it's a pretty big topic, and we're going to try to lend some time to each part of it so that we can kind of hit everybody's interest here. Conflict of interest and disclosures are here for you. Travel expenses honoraria from Ingmar Medical Medtronic, and I am also a consultant for Vyaire, and everything here are my slides and content and my thoughts. All right. This is my other disclosure. I really think I love putting this quote up when I talk about these kind of topics. If you are unfamiliar about the primary author here, unfamiliar with, his name is Luciano Gattoni. He is a titan of ARDS and mechanical ventilation research, as well as mechanical ventilation while in Ecmo research. He practices in Italy as well as in Germany, and has published 300 some odd papers. So he wrote this, really review article in 2017, and I will let you kind of read through here that first sentence, which is probably the most classic. If you read a lot of journal articles, I'm not sure that you would ever find this in an introductory sentence. But he kind of hits the nail on the head. So if you were tuning into this talk, hoping to find some sort of evidence-based answer about how to set up the ventilator while the patient is on Ecmo for ARDS, you can stop watching, but don't do that. All right. We'll talk about all the stuff that we do know. Okay. And we'll apply that physiology and that pathophysiology to these patients that are on Ecmo and what on earth we do with the ventilator. Okay. So I got four big objectives that we'll try to get through here. I'm going to quickly go through some of those fundamentals with the different modes of mechanical ventilation, just so that we can all be kind of on the same page as we go through, the duration of the talk, as we talk about the different ways that we ventilate patients and the different ways that we hurt them, right? And so that's what we'll talk about second. It is called ventilator-induced lung injury, and just because we put the ventilator on them doesn't mean that we do not harm them, all right? And so there's certain concepts and things that go along with that, and we'll discuss those. We'll also discuss in such ways to prevent them, and then we'll roll all of those ideas into, well, how on earth do we manage the ventilator once they get cannulated and are on Ecmo? All right, so off we go. Okay, so first part, fundamentals of mechanical ventilation here. So in terms of mechanical ventilation, the ventilator really can only do two things. It delivers two types of breaths, right? It delivers a spontaneous breath and it delivers a mandatory breath. All right. Those are the only two types of breaths that it actually delivers. Okay. How we set up those breaths is where you get into what you may hear called or be familiar with modes mechanical ventilation. So this is how we're going to organize ourselves here. All right. So once we understand that fact that the vent delivers a mandatory or spontaneous breath, it is up to the clinician there to set whatever or to choose what type of breath they want. All right. And so we're going to stay here as you're facing the screen on the left. We'll talk about the mandatory ways. All right. So a mandatory breath, the first step is selecting the breath pattern. And this is what I mean by that. So here we have breaths being delivered here, right? There's 3 of them across your screen here. We'll call this a scalar. Pressure, specifically airway pressure, is on the vertical axis. Time is on the horizontal axis. And what you see is 3 mandatory breaths. So the ventilator is turning on and delivering these breaths. And we'll make up the story here that the patient's apneic and has no respiratory drive. The ventilator will deliver these breaths even in the absence of that patient's apnea. And that is based on a timing criteria. That timing criteria is specifically based on your respiratory rate. So in short, what that means is if your respiratory rate is set at 10, 60 divided by 10 is 6 seconds. So every 6 seconds, the ventilator will turn on. And that way it evenly spaces those 10 breaths out over the course of a minute. All right. Once that vent is time triggered to start, it delivers the mandatory breath here. All right. So the question is, though, well, what happens if the patient wants to take a breath, right? In between here, denoted by that little V that I have there for you. And so that's the question. Well, what does occur if the patient wants to take a breath on their own? And what that is, the answer for us here is the patient or the ventilator doesn't ignore the patient's efforts, right? It doesn't lock them out, essentially. That would probably be cruel and unusual punishment, right? So what the ventilator does do, though, is sense that patient's efforts, and what it will deliver to them is the same exact mandatory breath as it was delivering when the patient wasn't triggering. And so what you have set up here is what I had termed first the pattern of breath delivery, essentially, in that every single one of these breaths, whether it's turned on by the machine or whether it's turned on by the patient, is a mandatory breath. So they're all mandatory. And that pattern of breath delivery is called assist control, or AC. And so we're starting to parse together what, the components of a mode of mechanical ventilation. Some ventilators call this CMV, or continuous mandatory ventilation. I'll give you a little tidbit. There are 298 modes of mechanical ventilation registered at the FDA. There are not 298 modes, there's 298 names for them because there are no rules for the proprietary naming of modes, right? So there's no generic naming or anything like that. So it becomes really difficult in practice, in teaching, and even in communication, because we can be speaking about the same thing, but in a different language, all right? So we're gonna go with assist control here, all right? And call this assist control, meaning all mandatory breaths. The next thing that the ventilator essentially asks the clinician to do at the bedside is, how do you want me to deliver all these mandatory breaths? I know that you want me to deliver them all in a mandatory fashion, but how do you want me to actually deliver them? And so you have a couple different options here. And I'll give you option number 1 is that you can set each one of these mandatory breaths to be delivered with a set tidal volume, all right? So let's just make up that we will deliver 500 cc's or milliliters per breath. So each one of these breaths, again, whether triggered on by the machine or whether triggered on by the patient, will be 500 milliliters, okay? And so in such, we have a pattern of breath delivery, which is called assist control. And then we have what's called the control variable, or how you control each one of those mandatory breaths, right? And that's volume. So what you come up with is the mode of ventilation is volume control, assist control, all right? I will lend this kind of tidbit to you here, is that this is typically shortened, right? It's a mouthful. It is the actual generic name for the mode, volume control, assist control, because it's telling me exactly the control variable and the pattern. But, in taking care of patients and in rounds and in the hospital, we typically shorten this to just say assist control with a understanding that that is volume. And I will say that is in a hospital that uses volume as its conventional mode. Okay, so we have to be careful about how we talk about these things. I always speak about them in longhand, volume control, assist control, because it's a complete nomenclature essentially. I'll then give you another option that exists, and it looks the same. It's so similar. It's very, very similar, except that each one of these breaths, instead of being delivered with a set tidal volume, is now delivered with a set pressure. And so lending the kind of the same pattern, instead of volume control, assist control, we would call that pressure control, assist control. All right. And so again, these can be shortened depending on the conventional mode of ventilation that you use at your particular institution, but these are the longhand names to them. Each of these ways to ventilate them, meaning whether you use volume or whether you use pressure, carries certain advantages as well as they carry certain disadvantages, right? And so in the world of critical care management of mechanical ventilation, there is no one mode that works for every single patient. There just isn't. There's also no data that proves that any one mode is better than the other, right? And so it is a matter of leveraging the advantages and disadvantages. And really those advantages stem from the physics of what's going on. Because if we control volume, then the pressure that is generated when the ventilator pushes that set volume into the patient's lungs is completely variable and dependent, right? And so that can be particularly advantageous, right? That you lose control of the pressure that's being generated. The advantage of it would be that you have, a set amount of volume going in and out of the patient every minute, which is called a minute ventilation. And that advantage lies in gas exchange, that you have a direct control of the patient's CO2. And now I'm speaking off membrane, okay? The advantage of using pressure is kind of clear, that you would then control the pressure that is going into the patient's chest or into the patient's lungs. And so, that definitely has a set of advantages, right? That you're trying to protect them from any sort of pressure injury or overstretching or something like that. But it also has a distinct disadvantages in that if you control pressure, then you do not control volume, and it is variable and dependent. Right? And so therein lies kind of a basic philosophy of mandatory ventilation. Okay. So further breaking this down into some granular details, and we'll talk about VCAC here. This is what a typical waveform looks like. And you can see each of the breaths are delivered, and they look pretty much the same here, right? They're all mandatory. This patient happened to be passive. And so wasn't, for lack of a better word, fighting the ventilator. And so they all look really, really similar, right? And so if we kind of break this down into granular pieces, you have really two primary ideas or controls when you're setting up the ventilator. And that is control of oxygenation, in which you control oxygenation by setting the FiO2 that you're going to deliver to them, as well as setting the PEEP, which stands for positive end expiratory pressure. And what you can see here, I think, on the scaler is that when the pressure comes out on exhalation, the green part here being inspiration, the yellow part being exhalation, it does not come all the way back out to this stark line baseline here. So the lung doesn't completely empty at the end of exhalation, thereby keeping it open. You don't want your lung to completely collapse on exhalation. So those are your two oxygenators. That PEEP helps your oxygenation by maintaining lung stability, maintaining the alveolus in an open position so that you have surface area for gas exchange, essentially. The other side of your brain, essentially, would be ventilation, right? So you have two sets of controls, one for oxygenation and one for ventilation. Those sets of controls that control ventilation are the respiratory rate and the tidal volume that we had kind of alluded to earlier, all right? And so those are your four settings, really, that you think about and talk about with mechanical ventilation. The FiO2 and the PEEP, the rate and the volume, and then the fifth one, there's the mode of ventilation, all right? As we move down into pressure, it looks really similar, super similar. The only thing I'm going to switch out here is how I'm controlling that breath. And instead of setting the volume, I'm setting the pressure there, okay? So nothing fancy, it's just a different way of delivering that breath there, okay? So that's really kind of summing up the mandatory side of things. We're going to jump over to the spontaneous and kind of make sure that we cover those and kind of understand what's going on with that. So with the spontaneous breath, clearly the patient has to have a respiratory rate and a respiratory drive because you don't set one. By definition, this is a spontaneous breath, right? And so the ventilator is waiting for the patient to take their breath. It's not going to deliver anything to them in a mandatory fashion, right? And really, when we kind of break this down and think about it, the ventilator has two options, and it's either to help them or not to help them. And so we'll take the latter first and kind of talk about, and what this is the ventilator chooses not to provide any inspiratory assistance to the patient, right? Doesn't help them take any additional volume in, doesn't push any pressure in. All it does is feed them an FiO2 and keep their lungs open with a certain amount of PEEP. And what we call that is CPAP, okay? So there's no assistance with that. The patient is essentially all on their own. We're just giving them a little bit of oxygen. The other option that I kind of had posed was the ventilator sees that particular effort on behalf of the patient and decides to augment their inspiration with a little bit of push or a little bit of inspiratory pressure to help them take a bigger volume that they wouldn't otherwise normally be able to take on their own. And that's what we would call pressure support, okay? So pressure support, what we end up doing and kind of breaking it down, you have the same oxygenator controls. You feed them oxygen, you give them FiO2, and you're setting a PEEP so that the lung doesn't collapse. And on the ventilation side, notice that I lose my respiratory rate, but I'm setting a little bit of inspiratory pressure. And you can see this on the scalar here. If I was on CPAP, I take away the inspiratory pressure, and what you would have is just a flat line all the way across here on which the patient is essentially breathing all on their own, okay? And so therein lies the difference between CPAP and pressure support. And then as you attempt to organize this from 298 modes of mechanical ventilation, which we could have spent hours and hours talking about, we've kind of whittled it down to what you need to know about 4 of them. Volume, VCAC, PCAC, and then CPAP and pressure support. And those are the, what I would say, I guess, conventional modes of mechanical ventilation, mandatory being on the left-hand side, spontaneous being on the right-hand side. And what we're going to talk about now, maybe it's commonplace in your particular institution. You've heard it talked about. We certainly use a lot of it, and that is what's called Aprv, which I'll be honest with you, is a little bit of a mix between the two of them. It takes the same ideas for that each of those mandatory and spontaneous have, that they kind of mix it. And so let's kind of look at this. This is the same kind of scalar graphic that you see, pressure being on the top, flow being on the bottom. We won't worry about the flow. I'll kind of direct your attention to the pressure waveform. And you can see that the ventilator puts pressure in, but it does so, kind of a little bit differently, right? Because it puts it in and it holds this for a really long time, right? So it puts the pressure in, and then that holding promotes lung recruitment and opening of what would be collapsed or atelectatic alveoli. All right, and so in such, you have 2 settings that speak to that idea. Putting pressure in, which helps to open the lung, and then putting it in for a long period of time, which helps to open those stubborn portions of the lung that are much more time dependent, right? And so what you have is what's called a P high, which is the pressure that I'm up top here, and I'm holding it for a specific length of time, which is called the T high, right? And so that you have a P high and a T high, and you leverage those for lung recruitment. At some point, though, you have to exchange fresh gas into the patient. You can't just hold this infinitely, right? And so you have to let bulk flow come out of the lung and then replace it, right? And so you then come to these other discrete settings here, which go right along with it. We're setting the time you spent up at the top pressure or the P high, and then I'm going to tell the ventilator, I want you to come down to a certain pressure, which is called the P low. Nothing earth-shattering or fancy there. And I'm asking the ventilator to hold it for a certain amount of time, which is called the T low. And what's happening here, again, is the bulk flow exchange of fresh gas into the lung. Notice here, though, that that time frame is extremely short with Aprv. And that is because what you're doing here with this P high and the T high is you're fighting for lung to open up really dense atelectatic areas of the lung. And in so, you improve gas exchange. You do not want to then go down to this low pressure, risk the lung completely collapsing on itself, and then having to do all of that work all over again, right? So decreasing this pressure to the lower pressure is done for an extremely short period of time. And what I'm talking about is 0.4 seconds, 0.5 seconds, something very, very, very short, as opposed to the time up at the top, which is more like 4.5 seconds or 5 seconds. And that short time frame doesn't give the lung an opportunity to completely empty when it drops down to that lower pressure, okay? So essentially you have 4 settings with Aprv, the P high and the T high and the P high or P low and the T low, okay? Now here comes the mix, and the next layer is that each of these pressures that the ventilator is holding, that P high as well as the P low, what the ventilator allows the patient to do is actually spontaneously breathe at each of those pressures. What typically doesn't happen is breathing down here at this P low because it's so short. You know, they can, and you just don't typically see it. And it's fine if they do, but you typically don't see it. What I've pointed out in each of the arrows is a case in which the patient took a breath on top of that P high, essentially. And so a lot of people describe this as 2 levels of CPAP. I'm holding pressure steady, and the patient is allowed to take those breaths. Every once in a while, I release the CPAP to a lower level in order to exchange fresh gas, okay? And so, you know, that in a nutshell is what Aprv is. All right, so we have 5 modes of ventilation, and you know, some of them we definitely use on Ecmo, but some of them I kind of threw in there, like CPAP, just for an understanding and fundamental purpose. We're going to kind of shift over to these prevailing concepts of lung injury now. All right, and so when I hope the rest of my graphics, these are a little messed up, but that's okay. I'm on a different laptop, but we'll keep going here. So when you are mechanically ventilating a patient, and we'll say under normal circumstances, right? Just typical non-ARDS type of patients, I think your probable primary goal is to make sure that they exchange gas, right? You certainly are worried about hurting them, right? Putting too much of everything in or too little of something in, right? And damaging the lung itself. But I think your primary goal is to correct ABGs. However, as patients get sicker and sicker and sicker, what ends up happening is that your focus and your main goals shifts. And now preventing lung injury becomes the primary cause for mechanical ventilation, essentially. We'll get by with, you know, gas exchange, but we better make sure that we don't hurt them, right? And so in preventing ventilator-induced lung injury, I think it's important to understand how we hurt them. There's a couple different ways. I put up 3 words there. I'm going to apologize for some of my graphics that look funny here. All right, they looked awesome when I last saw this on my other computer. But in any case, you have a couple different ones, and these are what I would describe as the well understood ones, right? The ones that have been studied the longest, have the widest dearth of evidence underneath of them, right? And that is volume trauma, something called atelic trauma, and oxygen toxicity. Those are the three big ones, right? There's some emerging ones as we start to understand better and better how we're hurting the lung, and we'll get to those. But these are the three biggies, okay? And those are our primary concern now. In correcting these ABGs, I'll give you an example here, and why we kind of shift our goals here. So in terms of volume trauma, really what that is, let's just kind of make up the example and just play off of the word, is that you're putting too much volume into the patient, right? And their lungs can't expand and accommodate that volume without overstretching themselves. And in such, you cause injury and inflammation, and you perpetuate what may be going on systemically, right? To correct that, you're going to clearly stop doing that. And so you would turn the volume down. When you turn the volume down, you will not ventilate the patient as much because you're not putting as much volume in and out of their lungs. And as such, their CO2 suffers. You stop ventilating them and the CO2 becomes hypercarbic. As they become hypercarbic, they also become acidotic, and we expect that. We, in fact, allow that to happen. It's called permissive hypercapnia. And this is what I'm speaking to here. In an effort to prevent lung injury, we make accommodations to the settings that we just talked about. But those accommodations have a cost to them, right? It costs too much to put the normal volume in, so we'll decrease it. But this is what ends up happening, is that we become more hypercarbic, or we have to turn the oxygen level down because we're just giving too much to a toxic level. So we turn it down, and therefore their oxygen saturation goes. Both of these are allowed. We let them happen. And so we rearrange our goals of ventilation and oxygenation here to stop making them normal. I've been doing this for 24 years, going into my 25th year, and I'll never forget one of the first things I ever learned, like 2 weeks out of school. I had all these grandiose ideas during rounds. I wanted to do this and do this and do that. And the attending that we were rounding with just looked at me, and he looked at the patient, he looked at me, he's like, come here. And we walked over to the door of the room, and he's like, Eric, look at that patient in there. And we all looked at him. It's quite embarrassing. The whole team was there. And he's like, Eric, are you looking at him? I'm looking at him. He said, Eric, is that patient normal? And I said, no, Dr. Phillips, that patient's not normal. And he said, then stop trying to make him normal, and you're going to kill him if you do. So I'll never forget it, 25 years. And I still tell the story to whoever I'm teaching kind of on this fundamental level. They're not normal. So they will live with these particular goals of ventilation and oxygenation. So let's kind of expand upon this and kind of draw some pictures. What you see on the vertical axis is lung volume, and I put lung volume in, right? And we'll say in this case, we put a little too much lung or too much volume into this patient's lung. And now we're overdistended. We're overinflating the balloon. It's overstretching, okay? And so there's a line at some point when that occurs. You know, too much, the volume up here is just too much, but if we only put in that much, then we're below this demarcating line of overdistension. And so what we have there is this example kind of from a pictorial sense of volume trauma. We also have this idea of this opening and closing. I somewhat referred to it when I talked about Aprv, and I also referred to it with PEEP. It is damaging to the lung if you let it completely collapse on exhalation. And it isn't damaging the collapsing part. What is damaging is when on the subsequent breath, it has to reopen. And it's not like this, delicate like reopening of the lung. It gets shredded open essentially, right? And so that opening and closing cyclic injury every single breath, if you let the lung completely collapse on exhalation, is a huge source of injury. And that is what we call atelic trauma. It happens at a certain level, right? Just like a volume trauma happens at a certain level. And so when we're taking care of these patients, you have to somehow identify these levels, right? When does volume trauma happen and when is atelic trauma happening, okay? So we'll kind of back out and we'll kind of think about what these levels are. One of them, one of the issues is we're just putting simply too much volume. A normal mammalian tidal volume, every mammal, has a 5.4 milliliter per kilo tidal volume. And when we speak of humans here, especially here in North America, we have to speak of ideal body weight. All right. So with their ideal body weight based on their height and their gender, we know their lung volume size. Right. And so we dose volume essentially approximately at what normal tidal volume should be. And so the volume should be 6 milliliters per kilo. If you go above that, and we typically allow a 6 to 8 milliliter range in non-ARDS or injured lungs. But if they become injured or they smell like they're becoming injured, you have to reduce the volume because it's not normal to have that much, right? And so you would decrease the volume here. And we alluded to this. We have our kind of first word that I want to introduce in terms of terminology. And the P, the capital P, stands for pressure. The subscript there is plateau, all right? And so a plateau pressure is a pressure in the lung at the end of inspiration. And it's not during inspiration, which can be quite high depending on the size of your endotracheal tube and the resistance and everything involved. But that's all occurring in the machinery and the conducting airways. What we're really worried about is the pressure in the alveolus, which we refer to as the plateau pressure. And what we know pretty solidly, right, is that you will start to overdistend your lung if the plateau pressure goes above 30. And so we do two things to prevent this volutrauma issue from happening. Two things that define this red line. We reduce volume to an operating volume of 6 milliliters per kilo, and we try to maintain that pressure, that plateau pressure, less than 30. And so we would reduce this volume, right? Now, speaking of this, the atalic trauma, what prevents atalic trauma is PEEP, right? If I increase the amount of pressure in your lung at exhalation, not inspiration, but exhalation, what ends up happening is that your lung will not completely empty, right? Our lungs don't completely empty, not intubated. We have surfactant, and we have what's called a functional residual capacity. So you and I walking around town have a built-in level of PEEP. As soon as we intubate somebody and that airway goes through their glottis, we negate the patient's ability to maintain their own PEEP. So we have to dial it in for them. And finding the right level of PEEP is tricky, right? Finding the right level of PEEP for that particular patient is tricky. So we have to set the right level of PEEP at this moderate level. And your idea here is you're painting the picture in your head is do not let the lung collapse and become atelectatic. And so you end up designing a breath or shaping the breath as it goes in. It is assist control, but those granular settings that we kind of referred to in the first couple of slides in terms of volume and PEEP become really important in preventing injury to the lung in these two mechanisms, volutrauma and atalic trauma. And so now, instead of letting it all the way out and then overinflating it, I have this nice tight little area in which I'm no longer injuring the lung. There's this third, this other mechanism of lung injury that is emerging. This paper here is 5 years old. This is affectionately within the critical care mechanical ventilation world called the driving pressure paper, right? And what this is, it was a fascinating study. It was an individual patient meta-analysis of, close to 3,600 patients, all of which were enrolled in the historical ARDS clinical trials about how to ventilate these guys. And so the authors went back and looked at the ideas that built upon what are kind of bread and butter, that volutrauma and atalic trauma. And they said, what really does result or cause mortality in these patients? Is it that volume? Is it the plateau pressure? Is it the PEEP? Or is it any of these other things, right? And so they did pretty sophisticated statistics, well beyond my understanding of statistics, right? But what they did was regression analysis and tried to understand what is most closely associated with mortality in these particular ARDS patients. And all the things that we talked about so far kind of, didn't really closely associate. Even the biggies, right? That you would say, wow, if I'm giving my patient 100% oxygen, they're probably going to die, right? And even that wasn't the most closely associated parameter. Even the Apache 3 scores, they're just got a laundry list of problems. That wasn't. But what it was, the most closely associated variable was this thing called driving pressure, which is the difference between plateau and peep. And so if we go back and think about, and I should have a graphic here that shows us, I have one coming up, but the difference between plateau and peep really is, if we think about it, right? And you think about a rubber band, and if you stretch a rubber band out like 12 inches, right? That end stretch, we'll say at the end of the stretch is 12 inches, right? If I start from 0 and go to 12, that is your driving pressure. The peep, which we said is 0, to the end of the stretch or the breath is the plateau, that's 12 inches. And so if I go from 0 to 12, that's my number. But if I say, I'm going to increase my peep here, and I'm going to increase it to 6. Now I'm going to stretch from 6 to the same end pressure, the same plateau of 12. The amount that you stretch the rubber band is clearly different, right? And so if you think about just doing that manually in the dexterity of stretching, really stretching far apart a rubber band versus only stretching it a little bit, you can kind of get a glimpse of, wow, that's going to hurt a tissue if I keep stretching it in such regard, right? And so that's what the driving pressure is how much you actually stretch from beginning to end during inspiration. So I have cumulative survival curves here, and the tidal volume, which we think is pretty important. Like I showed you that, right? We gotta reduce the volume and we gotta reduce the plateau pressure. Actually, didn't correlate with survival at all. There was no difference between whether we gave them a lot of volume or a little volume by itself, right? And if we looked at that all-important plateau pressure that I had also alluded to in the same regard as volume trauma, that line lays right on top of each other. Patients with a high plateau pressure versus a low plateau pressure actually wasn't correlated with death at all. It was exactly the same. However, driving pressure, you had a clear difference, a statistically significant difference in survival. Those with a low driving pressure or low stretch had much better chances of survival than those with a really high stretch during inspiration. And so that how much becomes really important. This is a survival curve here. Anything above 1, you increase your risk of death, right? Your relative risk of death is anything greater than 1. And so you want the driving pressure, which is along the bottom here, to be lower than 1.0, and that is somewhere right around 15 when that relative risk of death curve crosses that 1.0. And so we have to then think about this and kind of throw another idea of injury into the mix. And this is the graphic I probably should have put earlier, is that difference between the peep and the plateau, how much you stretch, called the driving pressure, matters. And it actually matters more than all of them. All right. This is an associated injury. It is yet to be causal. There is no prospective randomized controlled trial yet testing driving pressure. There have been several retrospective meta-analyses about the importance of driving pressure, all of them coming to the same conclusion, that it is the most closely associated variable. So I put it on kind of the tail end because it has no PRCTs with it yet to make it guideline type of material. But I can assure you, we pay attention to this all the time. Every day, every hour. What's the driving pressure? What's the driving pressure? All right. And so what this ends up looking like is that not only do you have to protect against volume trauma, and not only do you have to protect against atolic trauma, you also have to reduce the driving pressure in some way, whether that's by even using less volume or using even more PEEP. But in some way, you got to scrunch up that waveform that I have there so that you have a lower driving pressure and a better odds of survival. And our goal is 14 or less. We got to keep it 15 fine enough. That's where it kind of crossed the line. So we say don't go to 15. That's an equal risk of death or survival. We keep it 14 or less. All right. And so you have three primary big mechanisms how the ventilator actually hurts you: volume trauma, driving pressure, and atolic trauma. So strategies to prevent them kind of line themselves up like this. Well, like, all right, like, how do I set this up then? And, you know, we'll say that this is the roadmap. Speaker front ahead of me talked a lot about a roadmap, and the roadmap for treatment or support, mechanical ventilation support in ARDS is dizzying. You know, like, what do I do? But I think we have some clear indication of what to do, right? At least in the beginning, all right? The American Thoracic Society, European Society of Intensive Care Medicine, et cetera, all the major medical societies got together and published guidelines on mechanical ventilation in adults with ARDS. They did this about 3 or 4 years ago now, right? So in 2017. And the two very strongly supported recommendations are on your screen here. The first being what we just talked about, low volume ventilation, and you have to limit your plateau pressure. The second one was the idea of prone positioning. And I'll kind of go through this really quickly. We got about 15 minutes left. So we'll kind of speed through a little bit, but this is a landmark paper in mechanical ventilation. It's 21 years old now, so 2 decades, but it is the paper that told us what to do and what these guidelines are. It was a randomized controlled trial of patients that received 6 cc's versus patients that received 12 cc's per kilo. Right, there was a statistically significant difference in mortality. Those patients that received the 12 cc per kilo tidal volume had about 39% mortality. If you just reduce the volume to 6 cc's, it went down to 31.8. All right, and so that's what we do. That's why we do it. And in such, because we decrease the volume, you have to accept a different goal of mechanical ventilation. All right. So in continuing to move forward with some pace here, that second recommendation comes from this particular paper, which was in 2013. This is what's called the Perceva Study, right? And so that's what's listed down there. We had long used prone positioning. What the data prior to 2013 largely showed us that it improved the patient's oxygenation, but it had no effect on their mortality. All of those studies being flawed in power, in numbers, in protocols, in what they did on the ventilator when they proned them. They were all different, and nothing could be made out of them until until this study, which was a huge multi-center PRCT, 26 ICUs in France, 1 in Spain. They enrolled a ton of patients for a critical care study, all of them having severe ARDS with a PF ratio of less than 150. They randomized them into 2 groups. One group was a prone group in which they flipped them over on their face for 16 hours a day. They then gave them a rest for 8 hours a day. The other group, they just stayed supine. The way that they ventilated them was according to that study that I just showed you. So the mechanical ventilation strategy was not the agent that they were looking for. In fact, they kept it similar between both groups. They were specifically looking at, does proning work or not, right? The primary outcome of this trial was 28-day mortality. And this is your Kaplan-Meier curve. You had a huge reduction in mortality, close to 16 absolute percentage points reduction, which is huge in a critical care study. And practice changing. It is why if you spend any amount of time in an ICU right now, you see every one of these patients that are really sick, you see them prone if they're following any guidelines whatsoever at all. And so That's why we prone patients, because you significantly improve their odds of survival at 28 days, and it was sustained all the way out to 90 days. So hence, those are the two big recommendations. And now we have some semblance of a map. We conventionally ventilate patients. We diagnose them with ARDS. And at that diagnosis, we go into action, essentially. We use that low volume, 6 cc's per kilo. We limit the plateau pressure to 30, and you should prone them. All right. However, what ends up happening is you quickly run out of road in a lot of patients, close to 20%, right? 16, so 1 out of 5 patients, this bread and butter stuff, what we should do, doesn't work. You got to figure something out. All right. You got to figure something else out, unless you're okay with a 20% mortality, right? Which no one is, right? And so that's why you kind of keep going and keep looking. And so this road ends in a bad position. And I would contend it is basically this idea that in protocolized medicine, which I am a complete proponent for, don't get me wrong by any stretch of the imagination, we have to use these protocols. But in using protocolized medicine, you treat everybody the same. You can't you're not going to get away from that if you use strict protocolized medicine. What the key is when to hop off of the protocol, right? When to say this isn't working for this one patient. And so in particular, we have a little subset of patients, right? That this protocolized medicine of low volume, low pressure, prone positioning isn't going to work out for them. And so we have to figure out how to treat that one individual patient, how to individualize what we're doing with the ventilator for them, right? And maybe this works for some people, and maybe it doesn't work for other people. And we got to figure out what that patient's plateau pressure is, because although this may work for everybody, that particular plateau, it may be over distending and too much for this one patient that's still really sick. And although this level of PEEP may work for everybody else, we may need a different level of PEEP for them. And so somehow you have to figure this out. And this is kind of one way to do it. There's a gathering evidence base about how to do this. And it's by using and measuring and then using the transpulmonary pressure to guide your mechanical ventilation in those settings. And so what I mean by transpulmonary pressure is the difference between the pressure inside of the lung and the pressure on the outside of the lung. And that pressure on the outside of the lung is specifically the pleural pressure, right? The pressure that we talk about inside of the lung is that alveolar pressure, okay? And so transpulmonary pressure, that difference between the two of them, is becoming more and more and more important, right? And this is just the equation. It's the difference between them, alveolar pressure minus pleural pressure. The way that we get that, though, we clearly cannot put a pressure manometer in their pleural space, right? I'm not sticking wafers in them and measuring the pressure somehow. I have no transducer to do that. What we do have, though, and it's a pretty good surrogate, is esophageal pressure. And so what I do and what we do in our practice is that we have a simple gastric tube that has a balloon on it, and we insert it into the esophagus. The balloon lies in the retrocardiac position in the mid-thorax, essentially. We transduce the pressure inside of that balloon, and that esophageal pressure has been completely validated to be a surrogate for pleural pressure. Now, there's lots of, beyond the scope of this talk, there are little holes in that concept, meaning your pleural pressure is different at the top of your lungs and at the bottom of your lungs. There are some differences, but this is a pretty good measure. It's better than what you have without it in, right? Without it in, you're just guessing and wondering why your patient's getting so sick continuously, right? And so this is why it works. So let's say that you have a PEEP of 12. You're doing what you're supposed to be doing here, right? And you think you're doing okay. PEEP of 12 is holding that lung open. But what if I measure your pleural pressure and the pleural pressure is 18? So the pressure around the outside of the lung is pushing in here, and that is being counterbalanced by the pressure on the inside of the lung, PEEP, holding it open. And what can be predicted here is that the pleural pressure is going to win, right? It's going to completely collapse the lung, right? And the lung will de-recruit and become atelectatic. And now you're set up for atelic trauma, even though you think you're doing the right thing here, right? And so in this case, the expiratory, because we're on, speaking of exhalation, is that transpulmonary pressure is 6 or -6 here. And our goal here, just from my picture, is that you got to increase your PEEP here. All right, you have to increase your PEEP to at least 18 in order to keep this alveolus open. And so that, in a nutshell, is how you use this transpulmonary pressure to guide mechanical ventilation. You have to have the ability to insert these balloons. You have to be able to transduce them. You know, you have to have that expertise, but you know, more and more people are using it in this fashion. I'm going to skip this particular slide. So within the next 9 minutes that we got here, I can at least touch on some of these mechanical ventilation strategies and how we then put them onto Ecmo. And I'll just kind of preface this. We don't change the rules. We don't change the rules. We become a little more cautious, but we do not change the rules. What injures the lung off of Ecmo is the same thing that injures the lung on Ecmo. So I think we spent 50 minutes at least trying to build that foundation of volume trauma, atelic trauma, and driving pressure, the importance of those. And when possible, using that transpulmonary pressure idea, and then flip them over. It's the same ideas and same strategies. So this was a nice review about 7 years ago now about these things, these ideas that we talked about. What injures the lung? All right. And so it's the same thing as you look upon here. Allow the lung, just reduce the volume really, really low, limit the amount of pressure, make sure you have enough PEEP. Don't, limit the amount of FiO2, monitor the transpulmonary pressure so that you prevent these sources of injury, right? And so what we end up doing is kind of rearranging this idea for that particular sick patient, but you have to individualize it. You have to customize it, right? As much as you can. So this is what exists out there now, right? Which I will tell you, there's a paucity of data. There's none. There's hardly any. I'm not sure that I'll get to show you the one randomized control trial, but this is what we got, which is a whole bunch of people throwing it at the wall and seeing if it sticks type of thing. That's what's up so far, right? We're on to some things, but nothing guideline or earth shattering quite yet, but I think we're almost there. So in this paper, the authors summarize, the strategies based on ELSO, based on REVA, and then the two big randomized controlled trials that had to do with ECMO, but really weren't testing mechanical ventilation strategies as much as other things. This is just kind of what they used, right? And so in the ELSO guideline, I've drawn these for you. You can see what I'm doing here. I'm using 10 of PEEP and I'm limiting the amount of pressure a lot. So I'm going ultra protective. Before it was that plateau pressure of 30. Now I'm not using anything more than 20. The amount of PEEP that you use though here, based on ELSO, I would argue does not necessarily protect this patient against atelic trauma. It's pretty low. It's pretty low. In the REVA, with H1N1, they recommended kind of a range, which was the same range to a little bit higher range of 15 of PEEP with no more than 25 of pressure. But the same idea is if I drew those red dotted lines, you're staying within that little nook, that little area of safe ventilation. This is the Caesar trial, same thing, same exact thing. And then this is the Eolia trial, right? This is the big one that a lot of people talk about. And these are the two mechanical ventilation strategies that they offered that you could use. And you can see they're the same, right? That they pull the pressure down as an option, or they use that Aprv strategy that I talked about. But the pressures that you put in the lung are the same. So, whether you put it in for a short period of time or a long period of time, I'm still kind of following those rules. I'm going to quickly wrap this up because I'd like to leave you 5 minutes. I'm at the 6-minute kind of countdown here, but I'd like to, see if you have any questions. But I'm going to leave you with this. There was one prospective randomized control trial that was published last year, and it was well done. It was only a single center though. They enrolled 104 patients, and what they did is that they randomized them. They were all on VV ECMO. They randomized one group to get the ventilator settings guided by that esophageal pressure and transpulmonary pressure. That's how you set up your PEEP. You didn't guess at it, you actually individualized it versus what I just showed you. You guessed at it, you put it about 10 or 15 and, kind of hope for the best, right? Primary goal, successful weaning. Secondary goal, mortality. And I'm going to go forward here a little tiny bit, and we're going to get to the big endpoints, okay? So you can see transpulmonary pressure group here, proportion, this is the primary endpoint, the number, and then the percentage proportion of patients successfully weaned from VV ECMO. 37% successfully, or 37 patients, 71% successfully weaned versus that lung rest group, 20 of max pressure, 10 of PEEP, 48% reached a statistical significance. So did the 60-day mortality point, as well as the duration on ECMO, 11 days versus 16 days. So this is the first inkling that we have here, the first well-done prospective randomized control trial about what on earth to do with these patients on ECMO, okay? But in the absence of that, you have to follow the rules, essentially. We've been proning a lot of patients. You may see your ECMO patients being proned a lot, and that's because the literature is starting to be populated by such. There is no prospective randomized controlled trial yet. Hopefully there will be one soon, but I've just thrown 4 of them up here, all right? All within the last several years. So we prone a lot, almost all of our VV ECMO patients, unless something is holding us back, all right? So that's what we get, all right? Mechanical ventilation on ECMO, prevent the lung from injury, all right? This is what we talked about throughout the course here. We'd go ultra protective, much lower volume, a little bit lower pressure, keep the driving pressure lower, and prone them. There's this emerging idea of a wake ECMO, which we've dabbled in quite a bit, where we just extubate them. But these, I think, are your 2 options, all right? So that is 57 minutes, all right? So I'm gonna stop sharing, and we'll open it up. Is there any questions?
Yeah, thank you, Eric. We just have time for a little bit, but the chat board was just wide open. I think the consensus is that perfusionists don't get enough training in their schools with respiratory therapy basics. And I know from being in the ECMO or the ECLS clinical manager for our company that we're lacking in that as a profession. So your information was well taken. One thing I want to ask is, you didn't really focus too much on FiO2. At one point, it was thought that 60% was okay, then 50%. Now we're seeing a possible difference between 30 and 40% FiO2 relative to the inhibition of the adenosine 2 receptors. Do you have any comment on that?
So yeah, you're right. It's all about reactive oxygen species, which accumulate, that's a big fancy word for oxygen free radicals, right? The higher the concentration, the more propensity you have to form these free radicals, which cause cellular damage and cellular death, right? And then end up in fibrosis. Hard human study. It's a hard human study to do where you isolate the FiO2. I don't think anybody's signing up for that. I'm not sure any ethics board is even going to pass it, right? All of our data comes from animal studies in which we give them 100%. And yes, we're slowly, less is better, right? And that scale is going down. The numerical value typically thought of is 60% for longer than 24 hours. You start to incur those oxygen toxicity issues downstream. Well, I think what we're finding is less is more in this case, right?
Comment. Thank you for that. Last comment. Why would you want to recruit lung tissue while you're on ECMO? So a lot of people are using even lower tidal volumes on VV, say 2 to 4.
Sure. And you know what? We don't know. I think there is this idea that you're either going to go one of two directions. And, you know, in our practice, that's what we do. If the lung has any potential for remaining somewhat open with safe settings, then we go ahead and just gently keep it open, essentially. If there's no potential, the X-ray is a complete sheet of white, there's no aeration, we go away from the ventilator and we actually let the lung completely down. So we do a little bit of both. It is based on that potential, though. I don't know that we know which way is, I know we do not know which way is better. All right.
Excellent.
Yep.
Thank you very much, Eric.
Absolutely. It's my pleasure.
Yeah. Thank you so much for sharing your information.
Absolutely. Do you need the slides? I'm
Sure,
happy
you
to
can share
make
them
them
with us. That'd
available.
be great.
Yeah,
Okay.
happy to make them
Fantastic.
available.
Yeah, great slides.
Thank you.
Thank you.
Okay, absolutely. All right, guys, take care. Have
Thanks.
a great conference.